And we'll get started on time. So good evening, everybody, and welcome to tonight's webinar on Beyond MDT Team Care Arrangements, delivering integrated multidisciplinary care that truly matters. My name is Angela Heathcote. I'm from Eastern Melbourne PHN, and together with my colleagues from the PHNs across Victoria and Tasmania, we thank you for joining us tonight on this important presentation. I'd firstly like to start our evening with our acknowledgement of country. We would like to acknowledge the Wurundjeri people and other peoples of the Kulin Nation on whose unceded lands our work in the community takes place. We pay our respect to Aboriginal and Torres Strait Islander cultures and to elders past and present. We are committed to the healing of country, working towards equity and health outcomes and the ongoing journey of reconciliation. I'd also like to recognise those who are dialing in from other areas throughout the country and from the lands on which you are joining us tonight as well. Recognition of lived experience. We also recognise and value the knowledge and wisdom of people with lived experience, their supporters and the practitioners who work with them, and celebrate their strength and resilience in facing the challenges associated with recovery. We acknowledge the important contribution that they make to the development and delivery of health and community services in our catchment. So just a few quick housekeeping items before we move on to our main speakers for the evening. Tonight we're on our Zoom meeting. All attendees are muted and will stay muted throughout the session. Please ask questions via the chat box. We will be having a Q&A session at the end of this evening, so please pop all questions within the chat and we'll facilitate that with our speakers. The session is being recorded. All attendees will receive an email within the coming week or so from their PHN with a copy of this recording. And please also ensure that you join the session with your Zoom name, with the name that you use to register for the event. This ensures that we can send certificates to the correct attendees. So to do this, I'll just show you on the screen here, just making sure that you click on participants and you rename your name based on who is in attendance tonight. I'll just leave that up for a second so people can see that. So we're very fortunate to have three speakers that we're very grateful for their time to share with us tonight their perspective of working in general practice. We have Dr. Paresh Dowda, who's from Prestantia Health and Next Practice Deakin. And Paresh comes to us with a great portfolio of roles spanning across clinical roles, leadership, academic, consultancy domains. So we thank Paresh for coming to speak with us tonight. We're also very fortunate to have Brooke Shelley, a pharmacist, and Dr. Ryan Sheridan, a GP registrar, from both who work together at Ontario Medical Clinic in Mildura, and both sit on the Monash School Community Advisory Committee. We thank them both for being here tonight, who are going to present a case study with us. So just going through our agenda tonight, we're going to hear from Paresh, Dr. Dowda first for 10 minutes on just a quick overview of the MBS chronic care item changes. There has been a lot of information around this information, so we're going to just shortly cover this in our session tonight. And then we're going to move on to the real in-depth conversation that we would like to address tonight, and that's looking at practice in action. What does general practice multidisciplinary team-based care really look like in a general practice with allied health perspective? And then moving back to Dr. Dowda, we're going to move through beyond teamwork and how does this really look in general practice? And as I mentioned, we're going to have an opportunity at the end for Q&A. So I'd like to firstly pass over to our first speaker for tonight, Dr. Dowda. Thank you.
Great. Thank you very much for that introduction, and thank you everyone for joining us this evening. I'd like to also just start with an acknowledgement of country and acknowledge the traditional custodians of the many lands from which we meet today. I'm on Ngunnawal land in the ACT. As I think about an acknowledgement of country, particularly reflecting on this evening's conversation, I want to really just highlight the deep knowledge systems grounded in sort of relationships, reciprocity and care that Aboriginal and Torres Strait Islander people have. Today we're talking about team-based care, and the importance of collaboration, shared purpose is really invaluable when we think about team-based care. And those are values that have been long practiced by First Nations people and actually underpin our work in healthcare. So I just wanted to remind us of the importance of that. I'd also like to acknowledge on the next slide a colleague, Dr. Wally Jamal from Hill's Family General Practice. The next few slides I talk about in the first part of this presentation, we've developed together because we did some joint webinars around the chronic condition changes. Let's just quickly on the next slide go through what those changes are. So we are 5-6 weeks into the changes around the chronic condition management plan. What we've seen is a change to a single plan. So rather than GPMPs and TCAs, we got one chronic condition management plan. It's either a preparation or a review. So it's really a unified care plan now. The fee for it has been standardized. Doesn't matter whether you're doing a preparation of a new one or a review, it's the same fee. In terms of referring people as a consequence of doing that care plan, it's now a referral letter. If it's an allied health person, those EPC forms we had to do before are no longer needed. And you don't need to have 2 or more providers to be eligible for the coordination element of a care plan. You just need to have a chronic condition that's been there for 6 months or likely to be there for 6 months or more. In terms of the allied health access, there's no change. It's the same access as we used to have before. So the 5 visits, but it's now under a chronic condition management plan rather than a team care arrangement. Over the next couple of years, there is a transitional arrangement, after which the new arrangements will become mandatory. In terms of who can help us do the care plans, again, no change. Practice nurses can help us. Aboriginal health workers can help us as well with the new chronic condition care plan. I already talked about the eligibility. I guess the one significant change is if a patient is enrolled with the practice under My Medicare. So if they're My Medicare registered, the care plan has to be done in that practice. If they're not registered under My Medicare at all, it should really be done as before by their usual practice, the usual GP. And I guess the other thing to just highlight is home medication reviews. In the fullness of time, a patient will need to have a chronic condition management plan to be eligible for home medication review. Not in the transitional period, but eventually they will. So why? Let's look at the next slide. And you don't need me to tell you this data. Chronic conditions are highly prevalent. So 50% of all Australians are living with at least one of the 8 chronic conditions that AIHW report on. Multimorbidity is going through the roof in terms of prevalence. When we think about healthcare utilization and hospitalization, 55% of hospitalizations are related to a chronic condition. And what we know is primary care is critical in how we look after people living with a chronic condition. And so, with these changes around a chronic condition management plan, it kind of begs 2 questions for me. So on the next slide, the 2 questions really that it begs, I think, is, do care plans make a difference? It's a bit of a leading question. The answer is, of course, yes, but what's the evidence? And I'll share some evidence with you. And then the second question is, if it does make a difference, what are the components of that care plan that make a difference? So let's look at the first bit of evidence. Do care plans make a difference? And there's lots of research papers I could quote to you, but I'm going to speak to this particular piece of real-world data. So this comes from New South Wales. New South Wales have something called LUMOS, which is like an integrated data set looking at GP records, hospital records, death registers, PBS records, and brings it all together And what they did was an analysis, and this is a busy infographic. So I'm going to draw your attention to the bottom right hand of the infographic. So this is real world data on millions of patient records. And what it actually showed, if we just pick diabetes as one example of a chronic condition, if we go to that bottom right-hand corner, what it shows is that people who have diagnosis first recorded in general practice. So we diagnose in general practice the diabetes. Over the 2 years worth of data they looked at, there was a higher rate of attendance in the general practice. That continuity of care and people being followed up was greater. Hospital admissions were half, and they used less specialist or hospital outpatient services, and mortality was less when we compared to diabetes being first diagnosed in hospital. So real world data, it's observational data, it's not a randomized controlled trial, but it's lots of patient records in our health system, which kind of points to this, to the evidence. It kind of points to, look, if we look after people in general practice, if we follow them up, if we plan their care, there's better outcomes. If we look at the next slide then, what is it about the care plans we do that actually lead to those better outcomes? There's a number of things, and you have to look quite wide because there's lots of different evidence that kind of brings this together. And so this slide summarizes all that different evidence. So first thing is, let's make it patient-centered, have patient-centered goals that reflect patients' own values around what's important to them. Let's make it comprehensive. Let's not just make it about one little thing, one little condition, but let's make it about the whole person. So it's a holistic care plan. Let's also bring in the functional and psychosocial as well as the biomedical. So let's look at things like what they can do, the activities of daily living, the mental health, the social care aspects, the social determinants. Medication is a big part of care planning and what contributes to hospitalizations. So let's just make sure we bring the medication element into the care plan. What meds they're on, are they taking them, what the side effects are that they're experiencing. The key lifestyle factors, smoking, diet, activity, alcohol, are of course a big driver of chronic conditions. And therefore, let's just make sure we've got that in the care plan and the actions that are needed around that. At the end of the day, a lot of this is about behavior change. And what we really want to be doing is enabling people to better look after themselves and their chronic condition that they're living with. So self-management support and embedding that in the care planning process, as well as the care plan, is something that adds to it. One person isn't enough to look after a person with a chronic condition. It really is a team sport. The thing about having a team sport, though, is that team needs to work in a joined-up way. It needs to be coordinated. And so the care plan as a coordination of that team-based care, again, is what makes it work. Having reviews of that care plan, having a follow-up schedule, it's actually what brings it to life and makes sure that the actions are followed through. Having a good comprehensive care plan is really useless unless it's shared widely with the team and the patient. And one of the things about the changes from 1st of July is an encouragement. It's not mandatory at the moment, but a strong encouragement to upload to My Health Record and share through My Health Record. And of course, patient consent and activation. So being part of the process and being active in that process is really what's needed. So if we now drill down onto the next slide, why did the government and the department come up with the changes that they did? Well, it's partly because the MBS task force, which looked at it, what it heard is the previous arrangements had a lot of red tape associated with it, right? So the two care providers, the need to involve everyone before you can bill for a team care arrangement, lots of paperwork, lots of admin work, lots of faxing to and back. And because of all that complexity, half the patients with the care plan actually never had a review. So the follow-up wasn't happening. And so the recommendations that fell out of that was to simplify, replace the 721 and 723 with the one item number, which is what's happened. Enable allied healthcare as an output of that care plan, but simplify the process. That's what's happened. The red tape's been removed. And let's try and link the care plans to encourage continuity of care. So let's link it with my Medicare. And that's what's happened. So they're really the changes. There's been lots of discussion around, the financial bits. And if we look at the next slide, I guess I'm not going to advocate whether financially it's better or it's worse off. The thing I would say is it depends where you are and how you operated the 721s and 723s. And so if you look at this graph, it shows various combinations and permutations of, if you did a 721, how often you did a review. If you did 723s, how often you did a review. And what it actually shows is the red line is under the 721, 723 arrangement, and the green line is the new arrangements. That, depending on what your usual practice was, majority of people, if you look at the area under the curve, are going to be better off. It's averages, some people will be worse off, but overall, as a system, our patients and our practices are generally better off as long as we do the reviews. The thing, of course, the numbers, the finances don't take account of is the time saved by reducing the red tape. The GP time, the nurse time, the admin time, in terms of doing all that admin, the red tape, chasing things up, etc. And that time can now be repurposed to something that's clinically more meaningful. What it's actually doing is it's taking us to think about a population health approach. And if we think about a usual practice, let's think about a pyramid on the next slide. Let's think about 1,000 patients, which is roughly the average per full-time GP. If we look at those 1,000 patients in a full-time general practice, about half of them will be healthy. 500 patients will be healthy. About 250 of them will be at risk of developing a chronic condition. For those people at risk, we have the health assessments, the heart health checks that can help support a prevention agenda to try and prevent them from getting a chronic condition. However, some of them will get a chronic condition. About 200 of them, roughly, will have a single moderate chronic illness, and about 50 of them will really be people with complex chronic care needs, frailty, multimorbidity. Those two the last two populations I talked about, and maybe some of the at-risk people, are the people who are going to be eligible for a GP chronic condition management plan, right? And many of them will benefit from having a home medicines review and case conferencing. So what the changes are doing is it's actually driving us towards thinking about a population. And if we think about a very specific population, people with chronic pain on opioids, it gives me great pleasure to sort of hand over to Ryan and Brooke, who are actually going to present a case study of how they've done this in a very specific population. So thank you, Brooke and Ryan, and over to you.
So I think I'll let Angeline speak. She's got her hand up.
My apologies, everyone. I'm going to interject. Presh, there's a couple of questions posed in chat, and I think it would be helpful if we maybe answer them before we move on, because they're focusing on the technicalities of the chronic care management changes. I'm going to start with patient registration first, and then I'll come on to EPC. So the question there is, if a patient's not registered with My Medicare and you do a care plan and claim the 965, will that item number be rejected or not? We also have a comment there, an observation in terms of the fact that while the guidelines say you are eligible to claim, there has been some pushback and therefore, sorry, some have been rejected and they've been escalated to the department.
And look, this is a significant change for 25 million people around the country, you know, from Services Australia. So I think there have been those reports of, you know, exceptions coming through when it's been claimed. The guidance around the chronic condition management plan is if they're not registered elsewhere, and it's 3 months since they had the old version, then you're entitled to do a GP chronic condition management plan. Because it's the first one you're doing under the new system, it's a 965 rather than a 967. So it's the preparation of a plan rather than a review of a plan. Even though you might be reviewing a 721 and 723 you did 3 months ago or 4 months ago. So I think that's where some people are finding exceptions coming in, is they've put in the 967 rather than 965. So bear that in mind. The other thing I think that's been reported is if a doctor, so if, you know, let's say I work in 2 practices and a patient's registered in practice A with me, but they come to see me in practice B and I do the care plan in practice B, that will be rejected because then my Medicare registration is in practice A, even though I'm the same GP, because it's a different location, it'll get rejected. So that's some of the feedback I've heard around the reasons for those exceptions and rejections. There may be other reasons, but you know, the guidance says if they're not registered anywhere and it's been 3 months or more, then you can do a care plan, or of course, if they've got a new eligibility, you can do a care plan.
And there's a couple of questions here, Paresh, around the sequencing of APCs. So the first one picks up on the 5 visits. Does starting a new GP chronic care management plan mean they can have 5 visits? Excuse me, as from the one, or are the APC referrals already done and counted as well? And then there's another comment here, do patients still need an APC in order to obtain 5 free sessions? I think it's important just to understand the relationship now around access to allied health.
So my understanding is it's 5 visits per calendar year. Doing a new care plan doesn't give them a new 5 visits. It's 5 visits per calendar year. What's causing confusion is the transitional arrangements and the 18 months it talks about in the guidance. So the 18 months kind of refers to the currency of them being able to access those 5 visits. So it's got to be within 18 months if they haven't had a new one done. But it's 5 visits per calendar year. That hasn't changed. Sorry, what was the second part of the question, Ange?
Sorry, do you need an APC in order to obtain the 5 free sessions?
They need a referral. So if you do a care plan and you identify the need to see a particular allied health professional, then they need a referral. So it's on the care plan. You do a referral like you would to any other specialist to that allied health professional. Ideally, you would seek the patient's consent to share the care plan as well, or an element of the care plan relevant to that allied healthcare professional. And that's all you need to do. It can just be one allied health person. It doesn't need to be the 2, like or, you know, the 2 other clinicians, like in the old system. And yeah, it's just a referral. There's no forms, there's no EPCs. You don't need to wait for them to reply back. You don't need to specify how many sessions they've got with that allied health professional. However, I feel, and certainly colleagues I've spoken to, we kind of recommend, if you've got a good idea that they need 3 sessions with that particular allied health because you think they're going to need a couple of sessions with somebody else, then put that in the referral letter. It does create a problem from the allied health perspective in terms of they need to go to track when those 5 visits are used, because it's not sort of ring fenced in the referral paperwork, or mandatory ring fenced in the referral paperwork. But from a general practice perspective, no EPC forms, referral letter, share the care plan, being best practice.
So there's another question come in. We've been allocated visits in the referral letter so that there is a record for allied health, GP and patients. So that's more of a comment than a question. But I've got a question for you, Paresh, in terms of if I'm a patient with a single chronic condition, fairly active in my management, can I still have a care plan, and can you still bill a care plan even though I don't need allied health?
Absolutely. So if we go back to the purpose of a care plan, the purpose of a care plan is to support you, in this example, Ange, to do all the things I shared in that slide around what makes a good care plan, to support you in terms of your self-management, support you in terms of knowing what you need to do to better look after yourself. If there are things you need to follow up on, like blood test results, putting that in the care plan. With that, we might also, incorporate things like sick day action plans. So if you get unwell, this is what you do, Ange. All those things are going to deliver a better outcome for you as a patient living with a chronic condition. And that's what the care plan is there for. And that's why we should be reviewing the care plan frequently as well, because we can then track and monitor that you are following up on the things we jointly agreed and made a shared decision around when we did that care plan, including all your prevention stuff as well, bowel screening, breast screening, lung cancer screening, if that's appropriate, cervical cancer screening, all of that, immunizations should all feature within that care plan.
Beth, Ryan, one more question, and then I'm going to move on. So it's about reporting back. So allied health reporting back to general practice. Do I need to write a letter or report back after the last visit? And also, how does the GP know how many sessions the patient's had?
Yeah. Certainly the requirement to close the loop is there. So there's an expectation that the allied health person will reply back to close the loop around what they did, the actions they took, the outcomes that came as a result of the actions they took in the treatment they provided. And that's part of multidisciplinary team-based care, right? Is that communication is so fundamental, and the new arrangements don't take away from that. In fact, they strengthen it. There's a need for it, and there's a requirement for it.
Thank you, Paresh. Over to you, Brooke and Ryan.
Wonderful. Firstly, can I just say congratulations to everyone. We're only 5 weeks into this new care planning system, and it really has been no mean feat to have to pivot and get the patient to come along that journey with you. So well done to all. Won't be perfect straight away, but I know that we will work together to make sure it's within the best interests of the patient. So thank you for the warm welcome and for everyone joining us here this evening to talk about multidisciplinary care. We're zooming in from far northwest Victoria and Mildura, and that's the lands of the Latchi people of the Millewa Nation. So we pay our respects, of course, to elders past, present and emerging. So if you work in general practice, chances are you do have a strong relationship with your local community pharmacy. You've probably had a phone call that may have saved your bacon at some point. And many of you might have worked in the hospital system where the pharmacist is often the friendly face who is going to answer your questions when you're writing that very first ever script. PBS rules, S8 laws. I'm sure you've read some wonderful HMR reports from local consultant pharmacists who visit patients in their home, untangle medication chaos that's in the cupboards, and help chart a safer path forward in the cases of polypharmacy. So a GP pharmacist is a pharmacist that does all of those things, but instead of working in the pharmacy or in the hospital down the road, I do it right here with you in the GP clinic. So a GP pharmacist is a fully integrated member of the multidisciplinary team. So we're on site, we're using the same clinical software. We're in Ontario Medical Clinic today, and this is my consult room, and Ryan's consult room is just down the hall. So our focus is on optimising medicines for patients in real time, so right when the prescribing decision occurs. We join case conferences, support chronic disease management and deprescribing. We play a critical role at the transitions of care time, especially after hospital discharge when we know that patients' medication lists can have completely changed. We educate and help supervise GP registrars, lead clinical meetings, and run medication education sessions for the whole practice team. So in short, we're the medication experts embedded in your practice, helping you and your patients get the best from every prescription. So now none of us are really wedded to the GP pharmacist title. I answer to most things. I often answer to Brooke as they're yelling it down the hallway. But we do get referred to as general practice pharmacists, as on-site pharmacists. Embedded pharmacist is one the department uses a little bit, but I really would like to ensure that none of us call GP pharmacists clinical pharmacists, because all of my colleagues, it doesn't matter where we work, we practice clinically. So GP pharmacists for now, but watch this space, I suppose. Next slide, please, Angela. So when we talk about multidisciplinary care, we're really talking about building a team. And you can't see, but I'm pretty tall and I play lots of sport. And there is no one team that's made up of all the same style of player. You don't always need to have a whole team of tall people. I'm reticent to use an analogy in terms of cricket because it's a really boring sport, but that's what I'm going to go with. So when you're playing cricket, you've got batsmen, right? So they rack up the runs. We've got bowlers and fielders who take the wickets, all-rounders who can do a bit of everything, a coach guiding the strategy, a team manager keeping things running smoothly, and of course you've got the umpire making sure things are fair and safe. The captain, though, they are the focal point and no decision is made without them. So if you only had batsmen, you just simply wouldn't win when your team's turn to bowl. So just like in cricket, you make sure you pick the best players, but that's not determined by just one skill alone. You have to have the right mix for the opposition, and your team might change. But everyone really needs to understand how the game works. Everyone needs to want to win. So it depends. Healthcare is absolutely no different. So the community you serve, the workforce that you can access, the unique needs of your patient will help shape your multidisciplinary team. But the one thing that never changes is that the captain is always the patient. So most general practices actually already meet the definition of an MDT. So RACGP's Health of the Nation report last year showed that 92% of clinics have a nurse. So, 9 in 10 practices will employ a nurse. And then 52% have at least one allied health professional servicing the clinic. So that isn't sort of differentiated by whether that person is in the clinic or is a contractor outside of the clinic, but 52% engage with an allied health professional for their particular practice. So what this tells us is that multidisciplinary teams are actually quite common, but what we need to understand is what do they actually look like? How are they functioning? How are they being remunerated? And we need to get all of those things right if we want to strengthen primary care and deliver better patient outcomes. So I would like now to hand over to Dr. Ryan Sheridan. He's an ACRM GP registrar who works alongside me in an Ontario Medical Clinic. And for him, working in a multidisciplinary team is actually the only way he's ever known. Thank you.
Thank you. So I suppose the challenge with general practice and selling general practice to, I suppose, early career doctors that are still within the hospital system is that people are used to working in a multidisciplinary, like junior doctors are used to working in a multidisciplinary team in the hospital. You're always surrounded by the team of the physios and the occupational therapists and the speech pathologists and the pharmacy. And I think there's always this apprehension about leaving the hospital system into general practice and losing that network and sort of being on your own in with a patient, devising your own plan and not really having the same support network around you that you used to. And I suppose it was, you know, of incredible benefit to me to join Ontario Medical Clinic that actually does have a really well-established multidisciplinary team. And I don't feel, you know, that I sort of lost any of the sense of teamwork that I did leaving from a hospital where you are sort of one of many people. So despite facing patients, you know, one-on-one generally in a consult room alone, there's always plenty of support around. And multidisciplinary care teams within the general practice setting provide a safe, you know, opportunity to registrars to learn from other professionals and pick up the skills of specialists in other areas and have that sort of sense of support. So multidisciplinary care focuses on whole person care, and patients receive comprehensive management of medical, psychological and social needs. It results in better health outcomes. So combined expertise of multiple professionals leads to early detection of problems, fewer complications and improved quality of life. And shared responsibility. So it distributes the workload. Not everything falls to one person. You can sort of triage things based on people's skill set. And once you work with, you know, within a team, particularly when the professionals are on site, you sort of get to know how each other practice, what they're interested in, and, you know, triage and refer as appropriate. It also improves communication. You have regular collaboration, which enhances the information flow between professionals, so from GPs to allied health. And then also it's really nice as a GP to get that direct feedback from the allied health. So you're sort of not just waiting and not hearing anything, you get a lot of direct feedback, particularly when the allied health are embedded within the GP practice. And it also provides stronger clinical governance. So diverse professional input strengthens safety, accountability and quality improvement. As Brooke said, we have quite a lot of clinical meetings here at Ontario Medical Clinic, and just being able to bring tricky cases or PBS changes, new medications, things like that about how we would best implement change, but also flagging patients that, you know, have been members of our clinic for a long time, and we could maybe optimize things a little bit further and, you know, rationalize some of the medications they're on, and really focus on the patient-centered decision making. So patients benefit from having coordinated advice from multiple different people, and instead of having you know, a message undermined, I guess, having a message reinforced and making sure that everyone's singing from the same song sheet. And I think that overall it increases workforce satisfaction and retention. So I mean, professionals feel valued and supported when working part of a true team, and certainly having access to on-site allied health, it does decrease costs due to a reduction in duplication. If you can sort of access the same EMR, read the same notes, it's not doubling up on the workload that's already been done. And I think it's been particularly good as a GP registrar as well to come in and, you know, work alongside a lot of established GPs and a lot of you know, patients, as I said, that have been part of the clinic for a long time, and just bring a fresh perspective and maybe implement some of the newer changes that, you know, come out through medical education more recently. And also when patients have had a long-term doctor that maybe it's looking at transitioning across to another doctor, a more early career doctor, you know, it gives the opportunity for registrars to set clear expectations and boundaries with patients, and sort of the expectation of, you know, what you know, maybe termed medicine of the past and what the new best standard of care and best practice is within general practice. And I suppose, you know, one of the things that can be difficult as well is next slide. One of the things that's, next slide again, sorry. So one of the challenges can be, you know, particularly when you're coming in as a registrar for a patient that's been managed by a different doctor for a long time, it can be a challenge to know, you know, what medications are still sort of indicated and what medications could be probably optimised to something a little bit better. And I think the challenge as an early career doctor is that deprescribing isn't really the forefront of the patient's mind. They don't necessarily come in to stop medications. It's, you know, they come in for their knee pain or, you know, something or other playing up, and it sort of has to be initiated by the doctor generally, and sort of having that confidence to have the conversation. And particularly as an early career doctor, it can be difficult initiating the conversation around deprescribing because, you know, there is this expectation of deference towards professional etiquette and hierarchy, that you're coming in as, you know, the fresh doctor and, you know, sort of upsetting the established hierarchy, and also a reluctance to question a colleague's prescribing decisions as well. And, you know, it's sort of being part of a multidisciplinary care, it sort of does, you know, it can help taking a team approach, so it's not necessarily one person taking all the responsibility and driving. It's about shared decision making, sort of being led by the patient, but then reinforced by, you know, a supportive team as well, and making patients more aware of what other alternatives are available, particularly for medications that have been on for a long time. It can be difficult to sell to patients that there are better alternatives available. Next slide. So one of the things at Ontario Medical Clinic that we're particularly proud of is the chronic opioid cycle of care. And we were very fortunate to win the R-Wave Outstanding Contribution to Multidisciplinary Team this year, which we're very proud of. So again, I personally was very fortunate to join at the right time. So Brooke was obviously already embedded with their clinic, and she was the consultant pharmacist of the year nationally last year. And so it was sort of coming into a role that, you know, to be perfectly honest, I wasn't aware that pharmacists were in general practice, and I thought that that was going to be a sort of tool within the toolbox that I was going to lose leaving the hospital system into general practice. And sort of we were able to work together on creating this opioid cycle of care plan. So my final rotation before joining general practice was at the Austin Drug and Alcohol Clinic. So I was quite well versed in opioid sort of deprescribing and opioid replacement therapy and things like that. And it was a great opportunity to work with Brooke and establish the cycle of care to offer sort of an excellent standard of care to patients, to look at targeted deprescribing of opioid medications. So the opioid cycle of care takes a structured approach to chronic pain and opioid prescribing. So while sort of chronic pain and opioid use disorder are not the same, and they are separate, the Venn diagram, the overlap is quite significant, and it's sort of about addressing the concerning opioid use in people with chronic pain, particularly that have been on older opioid agents for long periods of time, that have seen, you know, progressive escalation of dose over time. And about having a referral process for team-based care of complex pain, and making sure you're utilising all sort of allied health services to achieve the best outcome for the patient. And to identify opioid use disorder early and initiate, you know, and have confidence in managing opioid use disorder, particularly through case conferencing with addiction medicine specialists where appropriate, and to set expectations around deprescribing and best practice of opioid prescribing from, you know, sort of the first consult onwards. And so particularly speaking as a junior doctor, as an early career doctor, teaching and education around opioid prescribing has changed significantly, particularly in the recent decade, and that there's a greater acknowledgement of opioid-related harm and sort of reducing down both the oral morphine equivalent that people are on and some of the older agents that maybe aren't a combination with naloxone, which has been shown to have better outcomes. And also among early career doctors, there is a greater hesitancy to prescribe opioids. And I know certainly I'm guilty of it as well. In the hospital system, you write the script for 10-endone and the plan is follow up with your GP for ongoing management.
Yeah, you're the GP.
And now I'm the GP and, you know, sort of having a plan about, you know, how you actually manage people's pain appropriately, and having the clear boundary setting to make sure it's not a problem that you're actually doing more harm than good when initiating opioids and particularly sustaining opioid use. And the program is aimed predominantly at opioid rotation and reduction. So it's more about consolidation of multiple different opioid agents. So, you know, for patients that are on, for example, Targin, Endone, and codeine, to maybe consolidate that into a single long-acting agent like a buprenorphine patch or something more appropriate. And as you're cycling through the different type of opioids, looking at trying to reduce the overall opioid, the overall oral morphine equivalent, because we do know that with time, doses tend to escalate as you get tolerance to the medication as well. So within our clinic, there has been a minority of patients that have been commenced on opioid replacement therapy, because I've done the MATOD training and it's an area of interest in mine. You know, but the case example that we're going to give is how you don't necessarily need to manage patients all the way down to opioid replacement therapy, is that, you know, consolidation, rotation, and targeted reduction can work as well without needing to reach an end result of replacement therapy. And I suppose the beauty of the chronic opioid care plan is that opioid use disorder and chronic opioid use and chronic pain normally exist within multimorbid patients. But for patients, pain normally takes priority because it's the symptom they're most aware of. Yes. And it's front of mind when they come into the consulting room, and maybe they're a little bit less concerned about what their lipid profile looks like or their HbA1c. And so I think as part of good multimorbid management, you need to focus on optimizing pain management so it's not the front of patient's mind. So you do get to move down into some of the really good quality chronic disease management, you know, like optimizing diabetes management or lipid profile that we know has really good outcomes. Next slide, please. So the example we give here is of Mrs. Gray. So she's a 64-year-old female, again, long-term patient of the clinic. She was being prescribed Kapanol, which is oral morphine. It was initially prescribed in 1999, probably earlier because that's when the EMR that we have here. So probably commenced on it more so for longer than 25 years by the time I first saw her, essentially. She was on an oral morphine equivalent of 80 milligrams. And the issue is that because she'd been on Kapanol for such a long time, there was some escalating opioid use because her pain was poorly controlled. It was impacting on her quality of life. And her long-term GP sort of had been on and off leave, which had meant that, you know, she did have difficulty getting her scripts, and it was causing a significant amount of anxiety around you know, where her medications would come from, in addition to polypharmacy as well. So she was also on pregabalin, temazepam that was nominally PRN, but was pretty regular use, amitriptyline and PRN codeine as well, which again, while PRN was being used quite consistently in addition to the oral morphine. And with the multimorbid conditions of chronic pain, diabetes and depression. So she was a former nurse and had caring responsibilities, and she was a frequent visitor of the clinic just because it was a challenging and complex multi-morbid situation, and her losing access to a regular GP and, you know, having a number of different GPs then sort of partially manage the care while a regular GP away was difficult for her because it wasn't like an ongoing regular contact with someone that she trusted. And the other issue was that it was really uncomfortable for the GPs as well, because not necessarily a plan that, you know, they themselves would initiate, but sort of once it's been started, sometimes it can be a little bit difficult to wind back. Next slide, please. So this might be a little bit difficult to read, but essentially The point is that I saw Mrs. Gray for the first time. It was a telehealth conference where she was calling for her scripts, which is always difficult, particularly as a registrar. Having a read through the notes, you know, as was already discussed, she was on regular Kapanol since 1999 for a back injury that she'd sustained about a decade ago. The last imaging she had of the back injury was in 2014, which did show some findings, but there was sort of no follow-up from the initial injury and no ongoing specialist management as well. It was being managed solely with the oral morphine alone. And it's sort of about meeting patients halfway, essentially, is acknowledging that the situation that she's in is incredibly unfortunate, being, you know, constantly refused by a number of different clinics and a number of different doctors about providing the script. And that you know, sort of not demonizing the plan that she was on, but just acknowledging that we can do better and acknowledging the fact that her pain was still poorly controlled and, you know, maybe it's time to try something else. When patients are on a management plan for a long time, they can be a little bit wedded to it. People, you know, don't change what, you know, what's the word that I'm looking for? Don't fix what isn't broken. Like if people are finding some benefit from it, you know, the preference is then to continue it. But sort of I explained that, you know, it's not the best standard of care that we offer in 2025, that it may have been an appropriate management plan in the early 2000s, but there are new medications available and that there are better medications available. And one of the things that we discussed was a rotation to a buprenorphine patch, which, you know, would provide an ongoing baseline level of pain control. And then to discuss the enrolment onto the chronic opioid use cycle of care plan, and that I'd be having a chat with the broader team to work out a tailored plan for Mrs. Gray and about how we'd best manage them. Next slide, please. So the beauty of having Brooke embedded within the clinic is that I was able to just chat with her. Well, initially it was in the corridor when we were walking past each other, but we did actually sit down to go through the notes and devise a plan. So we had more time to sit down and go through the, you know, recent prescribing or not only recent prescribing, the historic prescribing as well, and come up with a bit of a plan about how we would look at rotating across to the buprenorphine patch. So, you know, we sort of had a chat about how we would rotate from Kapanol, so oral morphine and PRN codeine, to a single long-acting buprenorphine patch, and then how we would sort of factor in an overall opioid reduction into that as well. So starting the buprenorphine patch at 20 micrograms, which would have been a 50% oral morphine equivalent, and then having room to move if, you know, we needed to, and again responding to the needs of the patient, but overall achieving a lower opioid use. And then once we were able to get the pain better controlled, is that look at doing some of the high quality chronic disease management stuff that, you know, we all talk about, but things like optimizing HbA1c, looking at doing a heart health check, and sort of optimizing the other medications as well through having Brooke do a medications review at her home. Next slide, please. So we jump ahead a little bit here. So we sort of enacted the plan, started off on the buprenorphine patch. And what came to light is that Mrs. Gray wasn't originally from Mildura, but hadn't left Mildura in 20 years because the last time she tried, she couldn't get her scripts filled at a different clinic, and so went into withdrawals, had to come back to the clinic, the pharmacy that she was known to, and since then had been, you know, sort of too scared to leave Mildura because not knowing where she was going to be able to source her medication. And once she was on the buprenorphine patch, was planning a trip to Perth, actually, where she was from, to visit her child and her grandchildren who would come to visit her in Mildura, but she'd never left Mildura to visit. So it was sort of a significant improvement on her quality of life. And it gave us time to sit down and talk about diabetes management and look at optimizing what we can do with the HbA1c and improve things like that. And once we'd sort of had quite a successful opioid rotation, as well as she actually volunteered what other medications can we look at and what other things can we look at sort of reducing as well, and reducing the number of tablets that I was taking. And, you know, so we're able to have a chat about the temazepam and the pregabalin, and also, you know, sort of said, we've got Brooke Shelley here. She's the GP pharmacist. She's the one that's, you know, also been involved in planning this around. What we can arrange is an hour-long review in your house about all of these medications. Brooke has a lot more time than I do to discuss this sort of stuff. And, you know, Brooke and I can have a chat here at the clinic once that's done, and we can, you know, move ahead with best managing you and, you know, your health, which was a real selling point.
Pretty well. Look, thanks, Ryan. We're so proud of this case and really proud of the work that we do at Ontario in the chronic opioid use cycle of care, because this is just good medicine. So what was happening with Mrs. Gray was that all of the other parts of her life were being undervalued, I suppose. Pain was front of mind all of the time, and this has allowed her to live a quality of life that is not only better than what it was, but allows her to have a good quality of life going forward. We did a great job with her diabetes management. I did a very, very long pregabalin wean using the Maudsley's deep prescribing guidelines, which is something we've spoken on before, but if you haven't had a look at it, talk to your local pharmacist or consultant pharmacist about Maudsley's deep prescribing. How I started in the practice, and maybe I'll get you to go to the next slide, Angela, was through my role as a HMR pharmacist or a consultant pharmacist. And so I was doing that work where I was external to the practice, but still part of the team. And being able to quite literally step foot into the building and have those corridor conversations. As Nick Richardson, I saw you commented that, you know, when you're a very busy practitioner, those corridor conversations are so valuable. They really are, because for you to call me in the community pharmacy, get through whole, you know, being on hold, press 1 to speak to the pharmacist, just to ask a simple question, it's so much easier when you just yell down the hallway. So when we talk about barriers and enablers to what we do, I think many of us know that they're mostly to do with systems and funding. It's certainly something that RACGP and PSA, so PSA is the pharmacy version of RACGP, I suppose. We are the peak body for pharmacists in the country. We are certainly working towards a model where there is a blended service model, and pharmacists can be in the practice, and that certainly will extend to other allied health professionals, and will likely be an extension to the WIP, which is very, very exciting. And I expect that it will happen sooner rather than later. But I think Paresh is going to speak in a moment more systemically around barriers and enablers. So I really just wanted to talk to you about what's working at Ontario and, you know, what's real and what's working for us on the ground. But basically we have the WIP, so the Workforce Incentive Program, that originally part of my wage was funded through that program. And as our team grew and our nursing capacity needed to increase, we have saturated that nursing workforce, the WIP through that nursing workforce. But it did support the initiation of the GP pharmacist role, and so did a PHM grant from PHM Murray. So thank you to them. But it really is team integration. So one of the biggest enablers is having me on site. And Presh will talk about how we integrate allied health who are not able to be on site, but certainly what we find is best practice is to be physically in the building and working at least 2 days. So it doesn't necessarily mean that your allied health professional will have, you know, a full 0.4 FTE, but even if they're a 0.2 or 0.3, that they're across 2 days, because when you're there, you know, some of the days and not others, and if you have time off, it's really hard to embed yourself in a team. Make sure you have a consult room for your allied health professionals, or at least a focal point where the GP knows where they are and where they can find them. Have a good internal messaging system. So whether it's email, whether it's the F8 functionality on best practice, or whichever EMR you're using, make sure and make sure they know how to find you. And certainly it's all about culture. So this didn't happen overnight. I've been in the practice for 6 years now. Lots of corridor conversations. Make sure you spend time in the tea room as much as you can. You can go to the next slide, Angela, that's fine. but certainly capability. So we've invested time into understanding each other's scope of practice, building that shared trust. That certainly helps us work together. But I would like to say that clarity about roles, responsibility and skills is certainly the first one. Communication, so if you're on site, that's a bit easier. If you're not on site, making sure you've got digitisation or some sort of robust system where you can communicate. Culture is probably the hardest piece. It's not just about your internal team dynamics, but it is shifting a whole system that's traditionally built on medical hierarchy and one that truly to one that truly respects every player on the team. And finally, capability. So it's not enough to just want to do teamwork. You have to build systems and allow teams to actually work together to practice to full scope. So, I mean, as I've said on the slide, collaboration doesn't just happen by chance. It happens when we value it, design for it and fund it. And that's really the heart of it. We don't just stumble into good collaboration. We have to intentionally create it, invest in it and make it part of how we deliver care every single day. So this isn't really something that we can afford to wait on. Patients need it now, communities need it now. Our health system really will only thrive when we make genuine multidisciplinary care the standard and not the exception. So thank you for having us this evening. We'll pass back on to Paresh.
Thank you, Brooke and Ryan. I'm just very quickly going to hand over to Paresh. Comments in there in terms of the extended multidisciplinary team and suggestions on who else may be relevant within that team, recognising obviously framed around patients' needs, and a plea for mental health and physio with regard to the case study you've presented this evening. So thank you so much for that presentation. Invaluable. Thank you. So Paresh, over to you to talk about thinking beyond teamwork.
Great.
Think about high-performing teams.
Great. Thanks, Ange. Thanks so much, Brooke and Ryan. I think what you described there actually underpins a lot of what I'm going to say here. And what I'm going to do is really do a little bit of storytelling, a bit like Brooke and Ryan did around how we're doing team-based care in our practice. And, you know, one of the wonderful accolades was we were in November last year presented with the Stronger Medicare Award by Anthony Albanese around the team-based care work we've done in the practice. So that was a nice little accolade. We took a population health-based approach, and if you look at the next slide, a bit like how Brooke and Ryan focused on, you know, that population of people with non-cancer pain and opioids, we took a similar approach, but we focused on three particular categories. So older people with complex and chronic care needs, and people living with limited life expectancy. And the reason for this was because when you looked at the data in our practice, out of 4,000 active patients, roughly 50% of them were over the age of 65. We have a disproportionately high number of people who are housebound, under NDIS with disabilities. And because of all of that, the number of people you know, with limited life expectancy in the last 12 months of life, palliative care is relatively higher as well. So that's where I guess the pain points were in our practice. And over the sort of 4.5 years the practice has been open, we've rapidly sort of grown the team. And this next slide, which is a really busy slide, so apologize for that, but I'm going to slowly take you through it, kind of describes where we are at the moment. And where we are at the moment, we call it an integrated practice unit. Interdisciplinary care, maybe another way of thinking about it. And so, you know, in the way we've approached it, and I love, Brooke, how you kind of talked about, you know, you can do this by design. And I guess we did a mix of doing it by design, but also being very adaptive as well. So what you see on the left-hand side is really our people strategy in order to look after those three populations I showed you on the slide before. What's the best makeup of the team we need? And then on the right-hand side, what are the drivers for that effective joint working, team working, what I kind of describe as the relational strategy, which is why, when I did the acknowledgement of country at the beginning, kind of emphasize the importance of relationships and relational ways of working. So let me describe the what. Let me describe the people strategy. So the green blobs you see are people in the practice. So we've got 7 GPs, 6 nurse practitioners, 5 registered nurses and 1 enrolled nurse. We've reframed our reception role into being a patient advocate role. So we kind of reimagined it. We've got a full-time social worker in the practice, and we've got 2 practice pharmacists, both working part-time. So it's about 3.5 full-time equivalent practice pharmacists, and they kind of sit within the practice. We also now got a geriatrician who sits within the practice. And we've got some allied health within the practice as well. So we've got a physio, dietitian, an oral hygienist, 3 diabetes educators, occupational therapist, and I'm just trying to think if I'm missing anyone, psychologist, accredited mental health social worker, as well as the social worker. And then we work really closely with some of the teams that support that, looking after that complex group of people. So there's a number of allied health practices. There's 2 allied health practices in particular that do outreach allied health. So reach into people's own homes and to nursing homes and that sort of thing. So we work really closely with them. There's a few hospital teams, mostly around hospital avoidance. So there's a radar team, there's a home-based palliative care team, and a team called the Grace team around aged care. So we work really closely with them and fostered strong relationships with them. And we're increasingly working with independent living communities. LDK is an example of one independent living community we work with, who provide that support at home for patients. And we're increasingly working very closely with their nursing team, the community nurses, because we're trying to achieve the same things for the same group of people. And that kind of takes you into the relational strategy. So if you look at the RACGP paper, consultation paper that came out last year on multidisciplinary team-based care, sorry, this year, but last financial year, so it came out in June. When we spoke to the RACGP back in November and talked about how we were doing it, I think some of the things that reflected in that consultation paper are things like culture and shared purpose. I think Brooke talked to that. Having some clarity of roles and responsibilities is really important, but I'll come back to that later, because we've learned that sometimes you've got to be really flexible and bend the roles and responsibilities to make team-based care work. Communication, you can't underestimate it. And teamwork and teaming. So there's teamwork in terms of delivering care, but you've got to work on being a team as well. And the reason for doing all those things is really to build trust, because without trust, and I think Brooke and Ryan, in your case study, you kind of described very clearly the trust between the 2 of you in terms of looking after that patient in the case study. And I think trust really underpins a lot of what makes good team-based care happen. Matt, thank you. We did have an exercise physiologist, but he moved on. So if you know any in Canberra, please ask them to reach out. If you look at the next slide, because trust is so fundamental, the question that arises is, how do you develop trust? And essentially, there's 3 things I think that lead to that. The first and foremost thing I think is a psychologically safe space, having that open communication. So being able to go to people in the team and say, I'm not sure about this, I don't know about this, you didn't do that, you didn't follow up on that, can you please follow up on this one? That sort of ability to just have open, honest conversations in a psychologically safe space. Really important. I think when you're looking at people like the case studies, Brooke and Ryan described, or people with complex and chronic care needs, that can sometimes feel quite overwhelming. So being able to share that in the team, to say, look, I'm really stuck with this patient, I don't know where to go, can really be powerful, and it helps build trust. Having that shared purpose, the interdependence, the mutual support, again, helps build trust. And then the reliability, that the roles, the competence, again, builds trust as well. So all those three components really come together to build trust. So trust isn't abstract. You kind of have to build trust by consistent behaviors that makes colleagues feel safe, confident, and aligned around that common purpose. And really the way we've started to do that, and I think Brooke and Ryan spoke to this, but if you look at the next slide, in the next slide, I kind of talk about team rituals. So certain things we do as a ritual. We have a daily huddle, 10 to 15 minutes, really short, sharp, key patient updates, prioritize care, flag any issues we're concerned about. We have a weekly meeting. So tomorrow morning, I've got a 45 meeting with one of our nurse practitioners who does chronic disease management, our social worker, our enrolled nurse who works as a case manager for those people with complex and chronic care needs, and myself. And we will discuss some of the most complicated cases. We'll look at their care plans. As part of that process, we'll be reflecting on our practices as well. Every month we'll have a sort of retrospective where we're looking at, how has the team performed this month? What did we do well? What could we have done better? We celebrate the successes. So yesterday afternoon, the corridor conversation is really important. So if you came to our practice, we've got a team collaboration room, which we call the Schwartz room. It's right next to the kitchen where the tea and coffee is made. And so you can't go past and grab a cup of tea without going to the team collaboration room. And we were in there chatting, and one of our nurses suddenly jumped up and said, oh my God. And she's just got an email to say she's just become endorsed as a nurse practitioner. So a huge celebration around that, So that kind of stuff really builds trust in the team. Sometimes we'll have joint care planning sessions. So today morning, we did a care plan on a patient with diabetes, but quite complex diabetes. So we did that together. So we did that together rather than separately. Doing stuff socially is really great. So a couple of weeks ago we had a team wellbeing meeting, and we had a patient who's got a close relationship with the practice actually come in and ran an art session, because we did art for well-being, and everyone had a little bit of wine, got a bit tipsy, and enjoyed painting. So team lunches and social times really good. Rituals around onboarding, and then really supporting that emotional well-being and continuous learning. So if there are things that don't work, and sometimes there are, in fact often there are, actually learning from that and debriefing to create that psychologically safe space. So team rituals is really important. Other than the team rituals, there's the other enablers. So Brooke kind of spoke to many of these. On the next slide, you'll see some of these things, and I'm going to just quickly highlight them. So communication tools, having that shared inbox, internal asynchronous chatting ability. So we use Teams chat quite a lot. Having shared care plans, really important. I think, Brooke, you spoke about shared documentation, accessing the same EMR, which was different from when you weren't in the practice to being in the practice, right? Multidisciplinary rounds, so sometimes we will see patients collectively together. So I saw a patient on Friday afternoon with our social worker last week. Team agreements around how we work as a team. So we've got that clear expectation of how we do that. Coordination of the team. When you've got lots of people in the team, you have to do that coordination. absolutely using the digital technologies to make it happen more effectively and more productively. Learning together, so interprofessional education, joint case-based learning, having team dashboards, so we're measuring outcomes and looking at outcomes together, including complaints, patient feedback, etc. And that, I spoke about psychological safety earlier, but having and modeling that behavior around psychological safety. So the way we kind of operationalize this, on the next slide, I talk about going from team-based care to teaming. What we found is teamwork works really well when you've got a stable team, right? So if you've got a stable sporting team that stays the same for 12 months, 24 months, 3 years, 4 years, you can work really well as a team. So teamwork's that collaborative approach, stable group of individuals, defined roles and responsibilities, all working towards a shared goal. What we've found in the 4.5 years we've grown in is everyone's working part-time. Very few of us now work full-time. So the team on a Monday might be different to the team on a Tuesday, although we all work in the same practice. And so this ability to work in a dynamic way, teamwork on the fly, becomes really, really important. And I've borrowed a lot of thinking from Amy Edmonton, who's a professor at Harvard University around teaming. And if you look at the next slide, it really kind of talks about the difference between teamwork and teaming. And look, they're not complete differences. They're not polar opposites. There's overlaps, but there's, some core principles. And if you look at teaming, that some of the core principles around this is having that fluidity, having the agility in the team, based on what the situation needs, around who's best placed to meet the needs of that patient at that time on that day. And that requires a lot of real-time adaptive communication, goals that are adaptive, but the clear focus is around being around the patient, focus around the patient. So high level of flexibility, rapid adjustments, and really just having that agility, I think, is probably the best way of describing it. The next slide then kind of talks about, if that's how we do teamwork, how is integrated practice units, which is how I described our team at the beginning, different from multidisciplinary team-based care? But, again, it's not one or the other. It's like a scale. And if we think about multidisciplinary team-based care as being a collaborative approach, where different disciplines work together, each bringing their unique expertise. So Ryan as a GP, Brooke as a pharmacist, to achieve a shared goal, typically related to patient care, right? So that the patient you described, multidisciplinary team-based care. Integrated practice units have a similar philosophy, but they're more about care delivery structures where the team, which is still multidisciplinary, work really collaboratively and cohesively around a particular population or medical condition with a like need. So sometimes our practice pharmacist will write the care plan. Sometimes our nurse will write the care plan. Like it depends on who's around, what's needed, and how it comes together. So the next slide kind of does a deeper dive into this, around the differences. And look, I won't, because we are tight in time, go through the detail on here. But the key thing I guess I'd want to pull out here is some of the things I talked about earlier, which is really the emphasis on flexibility and agility, but having a shared responsibility for the care of that patient journey, the whole outcome that's achieved around that patient. So that's kind of, I guess, the fundamental difference. And when I think about our experience of team-based care in our practice, and when I think about because I do a lot of research, I think about what's happening around the country, but also around the world. The next slide is a bit of a from-to slide. Where are we at and where are we going to? And again, I think everything you see on this slide, and I'm not going to go through it in detail because of time, but it kind of talks to that flexibility, that agility, the focus on patient goals and what matters to the patient, and the patient being part of that team, and the relational aspects, built-in trust, continuity, and shared accountability. One of the criticisms I hear, and sometimes I guess when we first started, I felt, is this is all great, but what about continuity of care? And if you look at the next slide, my thinking on continuity of care has evolved, because we often think about continuity of care as being a unidimensional construct, which is a relational one. That person seeing the same it's the same clinician each time. And there's a reference here from Lads and Trish Greenlow in the UK, who kind of talk about it being a multidimensional construct, which includes a relational, it also includes the disease episode, it also includes a sort of arc of distribution they describe, and it also includes the community. And this has resonated with me quite a lot. So if anyone's concerned about continuity of care and team-based care, I'd really encourage you to look up this reference, because it is really, really powerful. I think Brooke and Ryan have kind of talked about team-based care within a practice. I've kind of talked about our experience of team-based care within a practice. But I've also, I think, signposted that we work quite effectively with people outside the practice as well. So the next slide really talks about what are the implications of, I think, the learning Brooke and Ryan shared, the learnings we've had. How do we make some of those team rituals happen, even though we might not be co-located? Okay, so we can certainly use digital infrastructure to help us do this. Having that structured communication is really, really important. Actually, just being explicit around what we're trying to achieve, having shared goals and purpose, really useful. I think we can build trust and psychological safety, even if people aren't working in under the same roof as us, if they're not co-located. So many of the people on the right-hand side of our people strategy, the radar team, the hospital avoidance teams, the community nurses, we all share each other's mobile numbers. We often meet outside hours. We'll sometimes have clinical meetings together. So all those things I talked about that make a team work inside a practice, the team rituals, they all actually are important when you're not co-located. But how you make that happen is perhaps a little bit different. You need to work harder at it, but it's still doable. And I'm going to just wrap up because I think we need to have a few minutes for questions. I think what Brooke really articulated well was 6.5 years, I think you said, Brooke, to get to the point you're at, 4.5 years for us. And I love this quote from Atul Gawande. Transformation is not a single moment of change, but an ongoing commitment to improving process, outcomes, and experiences in healthcare. So I guess our teamwork and our practice at the moment is where it is. It wasn't there for 4.5 years ago. In fact, 5.5 years ago, it was me. I was the only single-handed person working in the practice. So we've kind of grown, but we've grown by purposeful design and being adaptive and taking a sort of learning systems approach. And with that, I'm going to just close on the last slide. And the last slide really is, if we go to the next slide, what you'll see is at the end of the day, this is about the people we look after, young, old. It's about our patients. And so let's try and do the absolute best we can for them together collectively. Thank you so much. And we'll hand over back to you, Ange, for comments and questions.
Thanks, Paresh. We've got a specific question here around your GPs. So in terms of, are they engaged as contractors or employed? But can I broaden that to think through how are the allied health, the nurse practitioners and everyone else in the team funded in your integrated practice unit?
Yeah, a mixture. So most of the GPs are engaged on a contract. Some of the allied health are engaged on a contract, but others are employed. So diabetes educators employed, nurse practitioners are employed, social workers employed, pharmacists are employed. So a mixture. And look, I think the mechanism of engagement, the mode of engagement, does have a bearing on some of this, and it can be an enabler or a barrier. But I think that the thing that overrides it being an enabler or a barrier is the culture and the shared purpose. So if you've got people with the will, the right intent, and the desire to work as a team, then you can actually overcome those enablers and barriers, or use strengthen enablers and overcome the barriers.
Yeah. And there's a specific one here. So if we think about the singularity of contractors, but you've just talked about shared purpose, values. So how do you get over that resistance for the GPs and other team members to actually come along to the team meetings, obviously not funded, but actually participate in those rituals that you talked about earlier, which again, are not perceived to be funded?
Yeah. So look, I think, that there are lots of competing priorities, right? And so how do we prioritize multidisciplinary care in general practice? And Brooke and Ryan, please feel free to jump in, because I think you've got some incredible thoughts on this. Our kind of thinking about this is we're framing the barrier not as a barrier, but as an enabler, right? So this helps you manage your most complex patients. It helps you reduce your workload. It makes you more efficient. It improves patient outcomes. We try and align it with incentives where possible. So CPD incentives, case conferencing. So tomorrow morning when we have the meeting for 45 minutes, we'll probably discuss 5 or 6 patients. 2 of them will be a longer discussion that meet the criteria for a case conference. And so we can at least build 2 case conference item numbers for those. The other 3 or 4 we discuss on top won't be billable, but at least we've got some remuneration out of it. So try and align it with what's available. Celebrate the good stories, like we've had some amazing anecdotes that we can share around patient care. The other thing is, when you start to do this, it feels like hard work, but after a while, you actually find it's professionally so much more satisfying. Like I have a bounce in my step when I go into work in the morning, because of the team. Brooke.
So I just think it's all about your culture, realistically. You've got any kind of team. Not everyone comes to the Sunday morning recovery session, but certainly you talk about the people that you want as part of your team. You need to find their pain points, what's in it for them, and I think Presh, you were speaking to the fact that, you might have a complex case or something that you might want to bring to those meetings. And when you have a few wins, that's when it starts to just become part and parcel of what Ontario Medical Clinic is. It's a team, and I'm sure that's much the same for Prestantia Health. It's really about what you're about, and people want to come and work in a place that really values that culture. So it's hard work, it's not easy, but once you've got that dynamic, that's actually your point of difference, and that's when people want to come and work with you. So I really encourage everyone to just make a start. That's all it is, just make a start. You're never too late. Too late is not a thing. It's the time is now.
And because I think it makes it so much easier as well, as when you have a bit of a personal relationship with the people in the team. And like, for example, Brooke and I have worked together for coming up 8 months now, so we both know both know how each other practices about, the sort of standards that I look for and adhere to, and, building that relationship with Brooke, making sure that we are approaching the problems from the same point of view and not undermining each other, and just is about that culture and putting in the work to get there.
Well, fabulous. Thank you, everybody. I think we're coming to time. I want to firstly thank Paresh, Brooke and Ryan for their time this evening and for all our attendees online. It's been a very valuable session to listen to your stories about how you approach multidisciplinary teams in your practice, your enablers, your barriers, how do you build trust and rapport? And I think that's such a valuable piece to take away from this session today. We want to thank all the attendees online. Obviously, multidisciplinary teams and in this space is a very important area that we as a PHNs are focusing on as we go forward with our engagement with general practice and with other providers, including allied health. So please take the time to please fill out the evaluation. We would love to hear from you what other information you would like to hear from us as PHNs and ongoing events or support. Everybody in this session will receive an email with including a copy of these slides as well as the copy of the recording, and certificates for CPD hours will also be provided to those who have participated tonight. So thank you everyone for your time for this session tonight, and we wish you all a good night. Thank you.
Thank you. Bye.
Thank you.